My name is Karlyn Powell, and I'm going to run through some tips on placement of lower extremity nerve blocks. We're going to start off with the adductor canal block. This block is useful for knee and ankle procedures as well as BKAs and some AKAs. It covers sensation from the knee to the medial ankle and can anesthetize nerve branches to the knee joint. The proximal end of the adductor canal begins where the medial borders of the sartorius and adductor longus align, which is approximately here. The distal end of the canal occurs where the femoral artery diverges from under the sartorius, which is approximately here. The image in the upper right shows the canal borders with the sartorius as the anterior border, the vastus medialis as the lateral border, and the adductor magnus or longus as the medial border. Other images of note include the saphenous nerve, which is the hyperechoic structure lateral to the artery, and the vastus medialis nerve, which lies between the sartorius and vastus medialis, which is here, and it's not always visualized on ultrasound. To perform this block, the patient is positioned with the leg to be blocked in a frog-leg position. The target is mid-thigh and low volumes of local are needed, typically 5 to 10 mLs. Larger volumes have the potential to spread proximally through the canal, causing a quadriceps block. Yet at the same time, volume is needed to allow a spread to the vastus medialis nerve if surgery involves the knee. These are more images revealing the anatomy of the adductor canal space at mid-thigh. We have our femoral artery, our femoral vein, adductor magnus, sartorius, vastus medialis, and the saphenous nerve. There have been questions over what level of the canal to block for coverage of the knee joint. This recently published study in RAPM found no difference in pain scores at rest, quad strength, or opioid consumption when the block was placed in the femoral triangle, proximal adductor canal, or distal adductor canal. However, they did find decreased pain scores on post-op day 2 for blocks placed in the distal adductor canal. This was theorized to be caused by local spread into the popliteal fossa, which provided posterior knee analgesia. And this brings us to discuss the IPAC block. IPAC is an acronym for infiltration between the popliteal artery and the capsule of the posterior knee. It provides coverage of the posterior sensory fibers of the knee and is helpful for analgesia in knee arthroplasties and ACL reconstructions. To find the target area, start with the probe and the popliteal crease and visualize the femoral condyles here. Move the probe cephalad until the condyles disappear, revealing the flat metaphysis, which is here. This is the optimal place to put the block. This block can be placed with the patient in a lateral position or supine with the knee bent. I find it easier to place the patient lateral and approach from the lateral side, but you can also approach from the medial side. If I approach from the lateral side, it allows me to avoid the saphenous vein on the medial side. You would advance the needle to the medial edge of the femur, which would be over here, and you aim between the popliteal artery, which is this, and the femur. As you withdraw, you give about 20 mLs of a dilute local, dilute being 0.2 to 0.25. A few tips for this block. Curvilinear probes can offer better visualization than linear probes. I have been able to visualize well with linear ones, so that shouldn't discourage you. If you approach from the medial side of the leg, be wary of the saphenous vein. Higher volumes can cause motor blocks with this block. IPACs can be used in conjunction with adductor canal blocks for analgesia. And however, studies have shown that IPACs are not beneficial if a surgeon also uses local infiltration. Now we're going to discuss the popliteal block. This block is helpful for ankle or foot surgery and BKAs and some AKAs, as it covers lateral and posterior sensation from the knee to the foot, as well as the tibia, fibula, lateral malleolus, and various bones in the foot. When scanning the popliteal fossa, structures of note include the popliteal artery, which would be down here, and the popliteal vein, which is located posterior to the artery, which would be here, the tibial nerve, which is lateral to the vein, over here, or actually on this image here, it would be over here, and the common peroneal nerve, which is here. As the probus moves cephala, the two nerves visualized join at the bifurcation to form the sciatic nerve. These images are short axis views above and below the bifurcation. If you're having difficulty visualizing the nerve, make sure the transducer beam is aligned 90 degrees to the nerve, or the patient can be asked to plantar and dorsiflex the foot, which shows the respective nerves moving towards the surface. The block can be performed with the patient in several positions, prone, lateral, or supine with the knee bent. 15 to 20 mL of local can be used. There have been questions of where is the optimal level to block in relation to the bifurcation, and it's been found that above or at the bifurcation provides a more reliable block than below it. For a dense, reliable block, the local should be deposited below the sheath, which will create a hypoechoic donut-like appearance. If the local is under the sheath, it's pushed distal within the sheaths, covering the tibial and the common peroneal nerves. Some pressure may be needed to be applied to pierce through this thick sheath, which may cause the nerve to be skewered underneath it. There is less potential of nerve damage if the needle is aimed at the space between the two nerves in the bifurcation, such as in here on these images. This is another image of the popliteal fossa below the bifurcation. Here you would see the popliteal artery, the vein, the tibial nerve, and common peroneal. And your target in this image would be right in here between the two of these nerves. This is an older study in which local was given at or above the bifurcation within the sheath, and they found no difference in onset time or success rate between the two blocks. The image on the left shows the sciatic block, the sciatic nerve surrounded by the local, creating the donut sign. The image on the right shows the two tibial nerves and common peroneal nerves surrounded by local anesthesia. So we're going to move on to the infrainguinal fascia iliaca block. This block can provide analgesia for anterior lateral thigh surgery, hip surgery, such as for hip arthroplasties and hip fractures involving a femoral neck fracture, not necessarily acetabular fractures, and for surgeries of the distal femur. It's also known as the 3-in-1 block, as it covers the femoral, lateral femoral, cutaneous nerves, and less reliably the obturator nerve. To place this block by ultrasound, the femoral artery would be placed on the edge of the screen, and the femoral nerve sartorius, let me get my pointer activated. So femoral artery on the edge of the screen, femoral nerve here, sartorius over here, and this would be your fascia iliaca. This hyperechoic strip connecting the femoral nerve just above the iliopsoas. Your target entry point would be approximately 3 centimeters lateral to the femoral nerve, or the midpoint of the iliopsoas muscle. And the target would be just below the fascia iliaca. This is a volume-based block, so 30 to 40 mL of a dilute local anesthetic would be used. And lastly, we're going to cover the suprainguinal fascia iliaca. This block lacks the infrainguinal fascia iliaca shortcomings by having a more reliable obturator coverage, and is useful as an analgesia for hip fractures involving the acetabulum. So this block is performed by placing the ultrasound probe medial to the ASIS and then sliding 3 to 4 centimeters in an inferior diagonal direction. the fascia iliaca is located between the deep circumflex arteries, which are in here, and the iliacus muscle, which is over here. And this is the fascia iliaca. The needle is inserted in a cauded to cephalid direction, and 40 mLs of a dilute local would be deposited. Signs of a successful blot include visualization of the local cephalid to the pelvic brim, this is the pelvic brim, and a compression or squashing of the arteries anterior to the local over in here. This study examined the optimal dose of local for a suprainguinal fascia iliaca in fresh frozen cadavers based on CT findings and a dissection of the spread. The volumes were based on a step-up, step-down sequencing. The study determined that 40 mLs was the optimal volume to cover femoral, obturator, and lateral femoral cutaneous nerves. And the images presented today originate from ASRA, NYSORA, USRA.ca, and Duke's regional YouTube channel. That's all I have for you now. Thank you for listening. I look forward to meeting with you in a few weeks in Round Rock.